Welcome, and thank you for tuning in to Stroke Busters, a podcast presented by the Institute for Stroke and Cerebrovascular Disease at UT Health Houston in Houston, Texas. The purpose of this podcast is to bring you the latest news and discussion in stroke care, research, community, and academia. I'm Amy Quinn, Communications Director for the Stroke Institute. Today's guest is Dr. Patrick Key, a non-invasive, board-certified clinical cardiologist with clinical interests in clinical lipidology, preventive cardiology, and non-invasive cardiovascular imaging. His Ph.D. research focuses on the metabolism of high-density lipoproteins, aka good cholesterol. He has an active research program in molecular imaging and targeted drug delivery using novel nanoparticles and intravascular devices. He is a member of the National Lipid Association and is up to date with contemporary management of various lipid disorders. He also runs a level 2 lipid clinic and preventive cardiology clinic at the UT Professional Building. Dr. Key joined us for Stroke Grand Rounds and stuck around to record this episode with one of our Vascular Neurology Fellows to answer some more questions so that we can share more of his insight and research. Let's dive right in.
Dr. Key, thank you again for joining us today. I'm Jerome, one of the Stroke Fellows, and I wanted to just dive in a little bit about the talk that you just gave us, as well ask some questions about some of your ongoing research outside of the clinical talk that we were just having. But just to start, the audience for our podcast includes not just stroke neurologists, also trainees in neurology, and as well patients, stroke patients and their families. So just to start, I wanted to know a little bit about the lipid clinic and this level 2 lipid clinic that we have here at McGovern, and maybe from a stroke neurologist perspective, when is a good indication to refer patients over to this clinic?
Yeah, so we are certainly operating at a higher level in terms of the lipid management. So usually the type of patients that will come to us are, if there's any uncertainty about managing the lipids in patients with like a strong family history of premature coronary artery disease and not knowing whether to start lipid therapy, or it could be a secondary prevention type patient who have already had a coronary or cerebrovascular event and not sure, how to lower their risk and getting the appropriate lipid-lowering treatment. Another type of patients that usually come to us are patients, with statin intolerance. It's a relatively common presentation, and like the patient has tried already all kinds of lipid-lowering therapy, but they keep getting side effects. Or another type of patients that I get are patients with a very complicated multisystemic disease. So some of these could be like patients with inflammatory conditions such as systemic lupus, or patients with HIV on the multiple type of medications that can interact with other type of medications. Patients who are transplant patients who also have drug interactions, and not to mention that they have accelerated atherosclerosis from a transplant itself, and also patients with other end-stage renal disease, and so some of these patients may come to me, and then there are also these patients with they have a history of hypercholesterolemia, but they are pregnant, or they need to have breastfeeding, so they will want to know if it is safe for them to be on a lipid-lowering therapy, yet they personally don't want to have any progression of the disease while they are not able to tolerate some sort of LDL cholesterol lowering.
Yeah. Okay, great. Yeah, definitely lots of reason to utilize the special, clinic that we have here. I also wanted to ask, maybe from a patient's perspective, the benefits of lipid lowering are very clear in our medical literature. But maybe real quick, from your perspective, how would you normally tell a patient, the reason to be on lipid lowering agents, whether it's statin or non-statin therapies, their overall benefits, for their health?
Yeah. So it depends on your target audience. It usually takes more effort, for in a primary prevention setting. I haven't had any disease at this point. Why docs? Why do I need to be on a statin? So those are the ones be harder to convince, and you need to present them with evidence of or so-called risk enhancer. So the 2018 guideline has been helpful in that particular fashion, and we have highlighted some of the risk enhancing factor that can guide us as to whether to start these patients on statin therapy. Yeah, and if there's any doubt, calcium score has been useful because if there's any calcium deposition in the coronaries, the patient can see it, on the images. So it's not something imagining, it's not just like treating a number, but you clearly have seen plaque formation in your coronaries. Or in other cases, could be your carotid ultrasound in the incidental finding, in your patients, or patients with a peripheral artery disease. Or even, a lot of patients have erectile dysfunction. You can tell them, they already have microvascular disease. So it is just a prelude to, further problem down the track. Another type of patients that I find also challenging to convince not to be on a statin, maybe a very young patient with a strong family history of coronary artery disease, and yet they come to you and say, well, really want to be on a statin, while I have a family history of this, yet the patient is in the 20s and the LDL is relatively normal, those ones, you also have, will be another difficult patient population to analyze the situation with them. Of course, the patients with declared disease states such as stroke or coronary events, you have to tell them that they're really not out of the woods yet after the stent is put in for the acute event, or if they have regained their functionality after TIA, it doesn't mean they can relax at that point. It's only that they've been lucky to be alive after that acute event, and now is really the time to be aggressive. Yeah, I keep telling my fellows, that it is very, very exciting to go into take a patient to a cath lab and do all these exciting things. But really, what is going to save your patient is systemic therapy and treating the patient as a whole, not only to prevent them from getting another coronary event, but also prevent them from getting a stroke, preventing them from getting a peripheral artery events in the future.
Yeah, great points. Awesome. And then kind of going, in addition to that, whenever you're talking to patients about maybe dietary changes that they can do for lipid lowering and as well to reduce risk for cardiovascular events, what types of diets or maybe even simple food changes do you usually recommend?
Yeah, so one very useful resource for all of you, we actually be going to the National Lipid Association, the lipid.org. They have some tear sheets that you can use. They condition the patient tear sheets that cater for patients with high cholesterol or high triglycerides, and also with obesity, and also patients with uncertainty about the so-called Mediterranean diet or a DASH diet. So that website has a lot of nice tear sheets with sample menu that patients could look at as well. But of course, it comes down to the patient themselves. Because if a patient's presenting issue is a high triglyceride, for example, especially for the ones with a level of more than 500 or even more than 1,000, the priority is obviously to lower the triglycerides before the LDL. Yet for other patients with triglycerides at a moderately high level, but also has high LDL and other cardiovascular risk factors, the priority there will be to lower the LDL. And so the diets could also change because, like, for example, the patient with very high triglyceride, I would use the tear sheet for a chylomicron cleansing diet for them and reducing the fat intake to less than 10% of the caloric intake. But yet, if it is a patient with mainly high cholesterol and coronary disease, those ones should be on a low fat and low carb diet. And a patient with diabetes, obviously, we also need to be on a low fat, low carb. And if obese, we need to also look into, weight reduction. So you have to cater, really, individualize your advice to the patient you are seeing.
Yeah, perfect. Yeah, these are great points. So in addition, I wanted to ask a little bit about the preclinical research that you do as well. Some really exciting projects over the past few years that you've been leading. There have been things related to nanoparticles or devices, intravascular devices, and liposome delivery of drugs, things like that. So I wanted to dig in a little bit more, and our stroke audience doesn't typically get to hear about some of these things that are sort of in development. So first, a little bit about the project related to nanoparticles. It sounds like to better visualize myocardial injury. How does that work? And I guess what were you able to find using these gold nanoparticles?
Yeah. So we have been having an interest in these molecular traces to unravel some of the biology in the myocardium and also in the vessel wall. So in the particular example that you are alluding to, we're looking at myocardial fibrosis, or in other words, a scar that's left behind after a heart attack. And because we know that the scar burden or the ischemic, the scar burden can be an indication of the amount of tissue damage you have sustained from your acute event, and also could be a substrate for cardiac arrhythmia in the future. So we want to see if we could quantify that, using a gold nanoparticles. And fortuitously, we have encountered a ligand that's expressed on the surface of some bacteria, and bacteria likes to stick to things with these protein. And in particular, in this case, it sticks to collagen, which is a major component of the myocardial scar. So we're able to use that particular ligand and connect that on the surface of the gold nanoparticles and see if the gold nanoparticles can get concentrated and home into this scar. And gold nanoparticle is a very good CT attenuating material, or metal. So we will be able to use that to quantitate the amount of scar. And gold also has a different energy level when comparing with calcium, which is the most abundant X-ray attenuating substance in your body, no matter it's calcification or the bony structure. So if you can use dual energy CT, you can differentiate between calcium versus the molecular tracer that you have injected. But furthermore, the gold nanoparticle is also a blood pool agent, very much like the contrast agent. So when you inject that, you can also use that as a way of evaluating the coronary circulation in the first pass. And then in the later phase imaging, you look at the scar. So you have both the anatomical information of the coronary circulation and also the burden of the disease and the scar formation inside the myocardium. So that was the initial goal of that project.
Yeah, that's really exciting. Are there, I guess, imaging modalities or, I guess in the pipeline, any imaging process now that's getting developed to use these gold nanoparticles in this way?
Yeah, so one of the Achilles tendon to these kind of treatment is it is an exogenous particle, and you need to prove their safety. And like a lot of the particulate material that inject into the body, gold nanoparticles also get picked up by the reticuloendothelial system, such as the liver and the spleen. And in our pharmacokinetic studies, we found that those particles, they stay in your liver and the spleen for a long, long time. So we really do not know the long-term consequence of these particles and what they're going to do to your liver and spleen and other end organs when they deposit there. Still, we know that we have injected gold in patients, right, in the past, for treatment of rheumatoid arthritis and other inflammatory conditions. We think they're relatively inert and relatively safe. Yet, when particles get into the nano dimension, they may not behave like bulk gold. It may behave differently. It may actually behave like a catalyst of some kind of reaction that we do not particularly understand. And one other issues with a lot of these contrast agents is that companies out there, they have an interest in developing a contrast agent that is multi-purpose. If you have it too narrow focus on just one particular application, the market is a bit small, and usually you will not get much traction and interest from the industry. So it's kind of difficult. You can have really fantastic results in the lab or in the CT scanner, but to have it being realized and being commercially deployed is a whole new set of issues.
Yeah, it'll be a long process. I think within stroke, maybe there are some researchers out there that can find this very interesting as well, because in stroke for brain imaging, we want to also be able to quantify where infarcted or scar tissue is versus maybe what's still viable tissue, even for acute decision making. We use perfusion imaging in that way, but maybe there is an application for the gold nanoparticles in some sort of way of identifying differences in tissue for the brain as well.
Yeah. And so you see most of the contrast that we use these days, in a science world, we could call them dumb traces, because they're not specific for anything. Like FDG, the iodinated contrast agent in the ultrasound world will be the microbubbles. They're non-targeting. They're very very rudimentary, but yet they have found themselves with a lot of applications. So those are the ones that are being commonly used right now.
Gotcha. That's a great perspective to learn about. Well, I wanted to pivot a little bit to a different project that you all have been working on as well, and really interesting paper that looks like came out from your group just last year about echogenic liposomes and I guess using them to deliver drugs directly to target lesions, atherosclerotic lesions, and then it sounds like even making them active by applying ultrasound to them. So walk us through this process, and then I wanted to start, thinking about how we could also apply this to stroke, endovascular procedures, and maybe new approaches to treating intracranial atherosclerotic disease.
Yeah, so that's interesting, because one of the applications of these microbubbles was actually for the dissolution of any thrombus in the cerebral circulation with the catheter-based therapy. So people have already tried, to inject these microbubbles and then get an ultrasound catheter to activate these microbubbles. So we know that ultrasound itself it's almost like a bit of a pneumatic drill, right? You can use that to loosen up the newly formed thrombus and get them to dissolve more effectively. But then they also feel that if these bubbles, they are able to get entrapped in these thrombotic network, and the application of the ultrasound may actually serve almost like a little explosives inside the clot, and then further just pop these thrombi and get them to be dislodged even more effectively. And you can even combine that with thrombolytics, but it has been still a challenge in terms of safety, and not to mention that the procedure can be quite specialized and quite cumbersome in certain ways. So I don't think it has been fully adopted at this point. But on the other hand, we also know that ultrasound interacts with these microbubbles as if you convert these microbubbles into what we call microsyringes, almost like microsyringes. So what you do that is the ultrasound. If you oscillate them, you disturb them, but not popping them. You oscillate them and get them to get smaller and bigger, smaller and bigger. You can squeeze some of the contents out. And so it's almost like a bit of a micro injector that if you can get these microbubbles to get close to your target and then to stir them up a little bit with ultrasound, you can be more focused and more targeted in your drug delivery. So that's the idea behind some of the work that we are doing now, and is to see how we can avoid generalized side effects, but at the meantime be able to deliver a very effective payload to the area that we want to treat. And in our case, it could be an atheroma that we want to treat, or it could be a stent that we put in, and we want to deliver medications to prevent any in-stent restenosis. So that is another piece of work that Dr. McPherson and I have been working on in the last couple of years, and we may be having a phase 1 trial in humans in the next year or two.
Yeah, that's really exciting. I think taking us into the future, hopefully we can take some of these technologies quickly over to the stroke side, because sometimes we lag behind cardiology and taking over some of these new ideas and new technologies. It would be great to try this early, maybe for whether it's carotid plaques or intracranial large vessel disease. There are issues, I think, that for our patients when they're acutely having a stroke, and then our endovascular team removes the thrombus mechanically, but then there remains a hot plaque or very thrombogenic lesion that becomes very difficult to clinically manage. So it might be really useful tool to be able to apply targeted drugs, or if they do deploy a stent immediately during the procedure, to be able to keep that open and not stenosed or occluded, just using these targeted medications and ultrasound mediated delivery there. Really interesting ways of applying this. Have you, I guess, considered some of these cerebrovascular applications?
I think another person in my group has been working with Sean Savitz in developing a neuroprotective agents delivery using our technology. So instead of a drug, we have been trying some bioactive gases that can be entrapped inside the microbubbles. And using the same technology, it could be intravascular or external ultrasound to activate these microbubbles near the brain or near the carotid artery. So I think it is an ongoing research that has shown in animal studies been reducing, the extent of stroke after some animal models. So that is something that is already ongoing.
Great to hear. And just so that we don't go for too long, I just wanted to ask last wrap-up questions just related to career development, for our trainees that may be listening as well. So, you've had a successful career in academics, so I wanted to hear a little bit about, how you got started, or maybe what advice you have for those early career fellows, junior faculty that are, trying to kick things off.
I think you have to have a curious mind, and your motivation has to be how you feel you can help your patients. Yeah. So, like in my career, when I was trained as a general cardiologist, I do have exposure, to interventions. But I thought, why these patients, still getting events after their initial intervention, and why these patients are so young and they get their initial myocardial infarction? Is there a way we can predict if these patients will have an event in the future, or if after they're treated, is there a way I can monitor the treatment efficacy? Because right now, we have very crude tools, and you have heard in the talk that what we have is LDL cholesterol levels, and we just wish for the best. If you can get below 70 or below 55, you're doing what you're supposed to do. You have no idea about what is happening in the vascular territories that you want to treat and to prevent another event. So that's why that set off my initial interest in molecular imaging as a way of predicting future events and also to monitor therapeutic efficacy. So you have to have an idea about what you want to do, and you want to see how you can do it. And so that's how I got into it in the first place. And you have to also, meet with the right people with the same interests as you, and share the same passion. And that's how you get started.
Great. Really wonderful advice. And thanks so much for taking the time for the podcast today.
Okay. All right. Thank you for your invitation again. Enjoy your crowd.
And that's it for this episode of Stroke Busters. As always, ideas and opinions expressed on this podcast are our own and are not a substitute for expert medical advice. Always contact your doctor before starting any program or therapy to make sure you are getting the best care tailored to your unique situation. UT Health Stroke is on social media. Follow us on Twitter, LinkedIn, Instagram, and Facebook at UT Health Stroke to stay updated on upcoming episodes, share with colleagues, friends, and family. For updates and the latest news on the Stroke Institute, go online to uth.edu/stroke-institute. Until next time, take care.